Okay, I guess I can continue talking a little bit about his trajectory. In the meanwhile, they fix the slides. Dr. Comair studied at the French Faculty of Medicine in St. Joseph University in Beirut. He then did an externship in the Central Military Hospital, also in Beirut. Dr. Comair then completed general surgery in the University of Montreal in Canada. Yes. And graduated neurosurgery residency in Montreal Neurological Institute, McGill University, and affiliated hospitals in Canada. Dr. Comair was then appointed assistant professor of neurosurgery in the University of California in Los Angeles in 1993. Dr. Comair was then appointed consultant neurosurgeon in the Cleveland Clinic. In 2002, Dr. Comair was appointed chairman of the Department of Surgery in the American University of Beirut Medical Center. And in 2006, he was made professor and vice chairman in the Department of Neurosurgery in Baylor College of Medicine in Houston. In 2012, Dr. Comair was named dean in the LAU Gilbert and Rosemary Shagari School of Medicine. And most recently, in 2022, Dr. Comair was named professor par in the Department of Neurosurgery in Johns Hopkins. Throughout his career, Dr. Comair has been recipient of numerous prestigious honors and awards that speak to his dedication to the field. These include the Neurosurgical Development Scholarship for Excellence, the Walter Penfield Award, the McNaughton Award of Montreal Neurological Institute for overall contributions to the Montreal Neurological Institute in 1989, the RPM Donaghy Award for cerebrovascular research in 1989, the Merritt Putnam Award in between others. Dr. Comair's scholarly contributions have made a significant impact in the realm of neurosurgery. Here are just some of Dr. Comair's most impactful research articles. Dr. Comair has an outstanding academic background as evidenced by an H index of 45 in Google Scholar and 36 in Scopus with more than 8,000 citations. Dr. Comair, this is the plaque that is already on your way. And once again, it's truly an honor to have you here. And in behalf of all of us, we extend our gratitude for you being here and extending your expertise. Thank you.
Thank you, Emiliano, for the introduction. It is a privilege and a pleasure to be invited to your department. And I want to thank especially Dr. Alfredo Quinones for his invitation. Today I will discuss my experience with surgery in the motor cortex. Let me share the so can you see my screen?
Yes, we can.
Thank you. So okay, so I will discuss today the surgery in the primary motor and the sensory cortex, and a little bit also surgery in the speech area. And it is, as I said, a personal experience and a review of the subject. This is a subject that I have been working on since I graduated from the Montreal Neurological Institute. And it is a special privilege to discuss this in your program where Dr. Quinones has made essential contributions to the field of awake craniotomies and has been both a pioneer and a major contributor. So without due delay, so first I will talk about the resection in the primary motor and sensory cortex. And as you know, resections of tumors and erythrogenic foci in the primary motor sensory cortex remain a neurosurgical challenge because there are few recently reported series, and there is a belief that resective surgery in the hand, arm, leg, and foot area result in permanent neurological deficits. And so in fact, these challenges are that the incidence of primary motor sensory cortex epilepsy, and for the same reason, tumors, is unclear. The EEG manifestations are not clearly reported. The choice of invasive EEG recordings as EEG versus subdural is also complicated, given the anatomy, the specific anatomy of this area, and given that with SEEG there is limited mapping of this essential cortex. The seizure outcome is not also very well described. There is a question when you are dealing with dysplasia in the motor and sensory cortex and also speech, is this tissue functional or not? Can you resect it without having a deficit? And more importantly, I think the most important question in my mind is functional outcome. What neurological deficit to expect short and long term? You know, before you take patient for resective surgery, you need to discuss with the patient the outcome of your surgery, and the patient would, you know, justifiably needs to know what type of deficit to expect, what type of recovery. Can he, you know, use effectively his arm or leg? Can he talk after surgery? And all these things are essential to be able to discuss before. And so I will try to do my best in clarifying these questions. So the motor cortex in man was described, you know, in 2 centuries ago by Hughlings-Jackson. And Hughlings-Jackson devised a doctrine, which we call now the Jacksonian type of epilepsies, a Jacksonian march. And surgery in the motor cortex was demonstrated by Victor Horsley. And he described in 1909 in the Lancet, in the Lineker lecture, the function of the so-called motor area of the brain. And also in the same paper, which is a very important paper, and I you know, recommend every neurosurgery resident to read, he described the functional recovery following resection of the hand, motor, and sensory cortex. And he demonstrated that following resection of the motor and sensory cortex, the patient can move his shoulder, and also he can move his arm, and there is limited hand movement. You can see here there is limited finger movement, but almost in his paper the hand was not useless, was useless. So it was a useless hand. This is a paper from Jonathan Miller from Case Western University, a recent paper published in Epilepsy and Behavior, where he reviewed the surgery in the primary motor cortex, and he describes only 16 series reported in the literature, including our series, and he reports only 280 patients. So from 1995 to 2017, only 280 patients were reported with epilepsy in the central cortex. Seizure improvement was 84.8%, and class 1 and 2 outcome was 67%. And he describes in the paper the immediate postoperative deficits. So only 58.4% had immediate postoperative deficit, which is unusual. You know, when you look patients, when you do resection in the primary motor cortex, you can expect in most cases deficits. In my mind, only patients who have cavernous angioma can come out without a real deficit. And then the problem is in all these series is that the deficits are described as long-term or short-term, and there is no further description of what type of deficit, what type of recovery, and long-term postoperative deficit is described at 23.1%. So another important paper is from your institution, the Mayo Clinic in Rochester, which also describes surgery for patients, or in fact, the approaches for patients with sensory motor cortex epilepsy. And in this very important paper, so they classified the risk, the post-op risk, as a acceptable risk or not acceptable risk. And it is difficult to understand what is an acceptable and what is an acceptable, not acceptable risk. For when the risk is not acceptable, stimulation of the motor cortex is recommended. And in my mind, stimulation does not work very well in the motor cortex. So the objectives of this presentation is to demonstrate that the primary somatosensory cortex is organized in 3 anatomofunctional units: the tongue face area, the hand arm area, the leg trunk area, and that extensive resections can be performed within 1 or 2 functional units, that reorganization occur and may restore function to a great extent. And including, and this reorganization would include the function of the hand and finger movements, and that this data is commensurate with experimental animal data. So this, in order to understand the motor cortex, it's very important to understand the embryology of the motor cortex and how the precentral sulcus come to exist. And you can see, so this is a paper from Turner described in 1948, and you can see that the central sulcus is a primary sulcus, and it is seen very early in embryogenesis. The post-central sulcus, which we call it the H sulcus, also is a primary sulcus that does not extend to the midline. And the precentral sulcus is not seen even early in life. It is a development from the first frontal sulcus and the inferior frontal sulcus. So the superior frontal sulcus and the inferior frontal sulcus mature, extend posteriorly, and create the precentral sulcus, which is a secondary sulcus, not a primary sulcus. That's why there is always a connection between the second frontal convolution and the precentral area, the motor cortex. And that's why also in the towards the parasagittal area, there is also an extension of the supplementary motor area in the primary motor cortex. And so you can see here that in this brain, we can see here there is a sulcus, intervening sulcus between the SMA and the motor cortex. But on the left side, the motor, you see the supplementary motor area is continuous with the motor cortex. And you can see here that the sensory cortex is also extending beyond the paracentral lobule. So this is also sensory cortex, and this paracentral lobule stops here. So you are familiar, very familiar, I think, in your department with this anatomy, and I would not dwell on it more. Suffice to say that in the motor cortex, you know, there is what we call the pli de passage, the inferior one, the middle one at the hand knob, that where the motor cortex is continuous with the sensory cortex, and also the pli de passage at the paracentral area. So for a review of this anatomy, you can take a look at our book that details this anatomy in detail. And in the surgery of the central sulcus, it's important to think of the vascular contribution of this area, and interruption, for example, of the central artery can lead to serious deficits. This is, I will not spend time. This is, as you can see here, the motor cortex, the hand area extend very deep into the corona radiata, and so you can see the extent of the primary motor cortex all the way down into the corona radiata. So our series, this is the epilepsy series. You know, I did not account for the tumors in all the tumors in this series, because in this series we accounted only for the patients who presented with intractable epilepsy. So tumors that was associated with intractable epilepsy. There are many other patients who had tumors in the motor cortex, sensory cortex, and speech that did not have intractable epilepsy, so we did not account them. So age at surgery is 26. Follow-up, again, a range is 5 years, but we have very extensive follow-up. and left 37, right 51. This is again this epilepsy series. So most of these patients have auras, sensory or motor auras. EEG is interesting because no spikes is detected on almost 28% of patients, central spike in 30%, and non-central generalized spikes in 42%. And the ictal EEG is non-localized frequently, almost 40% did not have a localized EEG because of the muscle artifact. And so 33 patients had neoplasms with intractable epilepsy. Sorry, I keep doing this. 29 patients had cavernous angiomas, dysplasias 22, and gliosis 4. And so the outcome, so 66% in class 1. So in fact, you would think that tumors would do very well, but in our experience, patients with tumors did not do as well. Many of them were in class 2 with tumors that were completely resected. Cavernous angiomas did the best. Dysplasias also did very well with surgery, and gliosis had the mixed result. So the location of the tumor is distributed here. So the patients have had tumors in various areas in the motor cortex. And this is a historic slide. This is from when we started doing it in Beirut. I don't put patients in pins. I still don't put patients in pins. I use a Mayfield headrest. And you can see here the navigation. So before electromagnetic navigation, I used to attach the spine frame to the skull, and the patient could move his head, and you could do very good navigation with this methodology of putting the spine frame directly, screwing it to the skull of the patient, and you can see here the resection in the motor cortex performed. So you are familiar with the methodology of stimulation, and I will not dwell on this. Dr. Quinones has made very significant contributions to the field, demonstrated that awake radiotomy is important to perform in patients with gliomas, that the extent of resection is much improved, outcome is improved, and length of stay is decreased. The cost of surgery is decreased. And this, I think, has convinced many people in the world to use this modality. Initially, in the 90s, when we started doing this, Dr. Richberger and myself at the Cleveland Clinic, people were very skeptical, but I think this has now gained worldwide acceptance. And also, the tracts that we deal with are also very well described in this very important paper by Dr. Quinones. So functional outcome, and this is very important. Motor resections, non-dominant face resection, you can expect a central facial weakness and dysarthria that recovers in 1 to 2 weeks. I'll show you this. In resections of the hand or leg, there is a severe deficit immediately after following surgery in the distal limb, immediately post-op, with proximal function still possible, much as Dr. Halsey has demonstrated. However, we show that the distal limb function started improving after 1 month on average. There is a gradual improvement not limited to the first months, and there is no plateau. The more the patient exercise, the more recovery there is. There is substantial but variable gains in hand dexterity. There is complete return of foot function, but no toe function after total resection of the foot area. And lesions located in the precentral sulcus, usually there is no significant weakness. So if the lesion is close to the precentral sulcus, you can expect no deficit at all. In sensory resection, the non-dominant face resection, dysarthria, no sensory deficit. All patients had severe sensory deficit immediately post-op. And what we mean by sensory deficit is not sensation in the hand, sensation in the hand and leg is concerned, but we mean by impaired position sense to touch and vibration. So touch and vibration is preserved. However, it is diminished, but position sense is totally disappears totally. So the patient can have a little bit of touch, but touch, but vibration sense is totally impaired. In foot leg resection, there is persistent numbness and subjective impaired of function. All patients gradually improved after 2 to 3 months, and one patient recovered at 2-year follow-up, and I'll show you this. This is a patient who presented at the age of 10 years with focal motor seizures, with in the left hand with secondary generalization. He had a previous biopsy of a right central tumor. This was a DNET. And so underwent resection. You can see here underwent resection of the motor cortex, total motor cortex resection. And this guy exercised. You can see his hand function, how he has recovered his hand function. This is another patient, 32 years old, right-handed, 6 years history of focal motor seizures, and the tumor in the motor cortex, splaying the sensory cortex. You can see here the sensory cortex. The tumor was in the face, hand area, and the leg, foot area was not involved. You can see here that, so this is mapping of the sensory cortex. Tumor was in the motor cortex. Stimulation of this tumor elicited seizures. And you can see here the depths of the resection all the way down to the corona radiata. This is the post-op MRI resection of the tumor and the sensory cortex still in place. And so this is a deficit immediately after surgery. You can see here that much like Dr. Halsey described, she has still shoulder function, arm function, but no hand function. And you can, so her leg is normal, and her face, you can see she has weakness in her, central weakness in the face. And this is later, so she has recovered a good portion of her hand function, still slower movement in the left. This is a patient that we reported, right-handed, 19 years old, long-standing history of intractable left-sided Jacksonian seizures, started by tonic contraction of the hand with secondary generalization, no sensory aura. This is, the MRI was totally normal, and this is her seizures. You can see version of the head, and then the focal motor seizures in the left upper extremity. Okay, and with a secondary generalization. So investigations with subdural electrode and ictal onset was exactly the hand area. So then mapping under awake. So when I removed the subdural, performed awake mapping and resection of the hand area, sparing the sensory cortex. And this is the post-op MRI. You can see here the hand area resected. This is sensory cortex, dysplasia on pathology, and this is on follow-up. So she has recovered her hand. She is now working in her father firm. She is handling all her father business. She has not had a seizure since we reported this as hand recovery. This is a patient, 17-year-old, right-handed, intractable epilepsy, aura of right hand paresthesias. And you can see here a dysplasia type 2 in the primary sensory cortex. The motor cortex is totally normal. So this lady, you could investigate with a subdural electrode. You can investigate with a depth electrode. But as you can see, the dysplasia and the sensory cortex sparing the primary, the parietal dominant cortex and the motor cortex. So I proceeded with this is her seizures, proceeded with surgery awake. So you can see the dystonic posturing of the right hand and the generalized seizure. So this is the MRI. You can see that the sensory cortex was involved with the dysplasia, but sparing the dominant parietal lobe. So this is surgery. So this is how we positioned her. So these are the ictal discharges, Palmini type of ictal discharges from the sensory cortex, and the depths of the resection all the way down to the corona radiata. And so this is to demonstrate what type of deficit you have. So as I said, touch is spared, some vibration sense is spared, but position sense is totally absent. So you can see here, this is the right hand. She can move her right hand well, but now as she, I'm sorry, I'm not a good photographer. So now with her eyes open, she can point to her two fingers, but when she closes her eyes, she misses, and this is a substantial time after surgery, she misses her finger. So position sense is disturbed, and this is now she's an architect. She has resumed, working and is able to write without any deficit. So, these are, I'll quickly show you, this is in the leg area. In the leg area, it is problematic because patients, when you resect the sensory cortex, they continue to complain of deficit in the foot for a long time because position sense is impaired, and so they don't know where their foot is when they are walking initially. With time, they recover completely. And so these are collections of patients that I will show you. This is a patient with the leg area. She recovered walking very well. This is another patient. And so I'll go, these are, you can see resections in the primary foot sensory area. And these patients also recover with time and physical therapy very well. So this is a patient who is a cook and now has resumed working normally. So I'll skip. You can see this. This is a patient with the primary hand area again, glioma in the primary hand dominant area, and full recovery at 7 months. So this is a patient who had this tumor for some time, then developed intractable epilepsy, and the tumor started growing. And she had minimal enhancement, also resection. You can see the depths of resection. So you have to make sure that not to get into the leg area, the pyramidal tract, the corona radiata. It's important. So I stimulate deep into the motor cortex and spare the fibers coming from the leg in order not to interfere with them. And the recovery of function with the hand. So I want just to say a few words about speech. So there is, the controversy with speech, as for almost 2 decades, was that speech was everywhere in the brain. But now, I think everybody came to agree with Dr. Penfield that speech is located in the Broca area. So the cortical aspects of free speech are located in the Broca area, in the Wernicke area, and also in the central cortex. And now workers in the field are all in agreement with Wilder Penfield work, and I recommend every resident in neurosurgery who's interested in awake rhinotomy to read carefully Dr. Penfield book on speech and brain mechanism. It's an invaluable contribution. So this is now everywhere acceptable. The only now new contribution to this is that in the precentral cortex, between the face area and the hand area, there is a major also speech area that is very important for initiation of speech and for motor planning of speech. So the speech is rhythmic, well planned. And this is the area that projects to the supplementary motor area and contributes to the ascendant tract. And this is a new contribution came about from looking at the nodes in the brain, and now demonstrated also by the Silva work. So the cortical areas essential for speech are now very well described. Then the tracts of speech, I think there is a lot of controversy regarding the contribution of the tracts, the important tracts to speech. And this contribution came out following this important paper by Sauer that demonstrated that speech, in fact, like vision and hearing, has a ventral and dorsal pathways. This was already discussed by Hickok, that there is a dual stream for speech, but in fact, the people that demonstrated this dual pathways for speech is Sauer from University of Freiburg. And they did this is a very important paper published in the Proceeding of National Academy of Science, and they did a very nice functional MRI study coupled with tractography, and demonstrated that there are two important speech tracts. The first one, as you know, is the arcuate fasciculus, and the arcuate fasciculus is located in the depths of the insula, just at the superior border of the insula, in the depths of the corona radiata, and you can see it is here. And another tract is the external capsule and the middle longitudinal fasciculus, which is located at the inferior portion of the insula. And then after this paper, there was a lot of discussion about the contribution of all tracts, and neurosurgeons from a lot of countries tried to put a specific description of function to every tract. And I think this is, in our experience, not the case. The tracts, it's a reflection of the cortical area, the speech area that is above the tract, and the tracts that need to be spared is the arcuate fasciculus and also the extreme capsule tract. And so with stimulation, there is, we need to look where are these tracts and spare them. And I don't feel in my practice that there is a specific function for these tracts. And suffice to say that the macaque monkey and the human brain are very similar. They have exactly the same tracts. They have the same cortical areas for speech and the same tracts. And so it is, I think, over demonstration of this tract is not feasible or conducive to any important function. And so this is the extreme capsule tract, which is in fact a fanning tract that compromises the uncinate fasciculus and the inferior fronto-occipital fasciculus. All of them are exactly the same tract. This tract can be removed its anterior portion, much when you do an anterior temporal lobectomy. However, the mid-posterior portion of this tract has to be saved in order to be able to continue with a normal speech function. And unlike the motor cortex, where I can go provoke a deficit and expect the patient to improve, in the speech area, before we continue surgery, while I am mapping the patient awake, I wait for the patient to recover totally before I continue resection of tumors. And this is a very important map to know where are these tracts in relationship to the insula and where we should be able to spare them. And with this in mind, you can do very extensive resections of the speech tumor in the speech cortex if you map speech carefully and if you spare the tracts that I have indicated carefully. And these are the various resections we have performed, as you can see in the speech area. So now, how function can recover? Why motor function recovers and speech does not recover? Functional recovery mechanism should explain the persistent proximal limb function in the immediate postoperative state, the progressive recovery of hand dexterity following complete resection of the hand-arm area, and the absence of recovery of hand distal limb function following hemispherectomy. So as you know, when we do hemispherectomy, patients don't recover at all. There is no recovery of hand function and leg function following hemispherectomy. So why when we do more focal resections, there is a recovery? And this is from data from Rouillet et al. And there is a lot of other data from the same lab that following M1 resection lesion of the hand area in the newborn monkey, functional recovery is due to the shift of hand representation to adjacent M1 territory. So the foot area, leg area, or face area take over the hand area. And this is in the newborn. However, in the adult monkey, recovery was slower, more progressive, and it is due to reorganization in the primary motor area, including the SMA. And so when you do a resection of the primary motor cortex and the SMA at the same time, recovery is far more complicated. Patients take a longer time to recover, and they continue to have some deficit. So this is from their paper, and I recommend, if you are interested in this research, to look at this paper. This is from Montpellier, and the patients here, they included patients who had strokes in the motor cortex and demonstrated that following a stroke on the motor cortex, recovery occurred by what they call vicariation, and so the leg area took over function of the ischemic hand area. And so how can the leg area recover? It is because there is in the motor cortex variable localization of the function. For example, the forearm is here, this is the motor cortex, here and here. So there are, if you microstimulate the motor cortex, the hand is not in one area, it is diffused over several, it's an extended area, same for the fingers, same for the foot and leg. So if you lesion, let's say this area will take over, and it will take over. And this is from Penfield work, as you can see here, that there is function of the fifth finger here, here, and here. So this is not exactly it is not as depicted in the homunculus, in the cartographic map. It is, when you look at the detail, you can see that there is variable distribution of the function. And so this is from a paper by Schreiber in the Journal of Neurophysiology on the motor cortex. And he compares the motor cortex to a piano. So for example, if you want to play the notes in A with two hands, it's impossible to play the notes in the keyboard with two hands, because you cannot put your hands across these 5 notes. However, if these 5 notes are adjacent to each other, you can then play them with one hand. And this is the distribution that we see in the motor cortex. So also, functional recovery depends on the integrity of the corticospinal tract. So if you lesion the corticospinal tract, no recovery can occur. And you can see here, where is the tract? You can see that the tract is exactly under the motor cortex for the SMA and the motor cortex. And so this is again where the tracts are, and that that recovery is also depending on training. The more you train, the more you undergo physical therapy, the better recovery. And so I will conclude here to say that our understanding of the motor areas is still evolving, particularly how the brain selects the optimal strategy for functional recovery following cortical lesions. This is not also even more complicated for the speech, and clarifying this mechanism is an essential prerequisite for the development of improved therapeutic procedures. And the hope is that you continue to contribute to this development in your outstanding department. Thank you very much. And perhaps I took more time than I was allocated. Thank you.
Thank you, Dr. Comair, for a very stimulating lecture indeed. Does anybody have any questions?
Yeah, I have one. Is there extensive? I'm sorry, David Miller. I'm one of the interventional neuroradiologists, but fine. Is there extensive differences in the overlap that you've seen between patients? How unique is it, and how much commonality can you find in the overlap patterns that you describe?
It is, in fact, there is a commonality that you expect if you do a focal resection in the hand area that your patient with training can recover dramatically their hand function, and including the finger function, if they undergo physical therapy. It depends, like the monkey experiments, it depends a lot on how extensive is the physical therapy. So I usually do not promise my patients total recovery. I tell them that there would be a very good recovery of their hand or leg following focal resections. But I usually shy away from telling them that there will be a total recovery. In speech, as I said, I do not inflict a real speech deficit when I am doing a resection of tumor or epileptogenic cortex in the speech area. While at surgery, I wait for speech to recover, to continue, or completely recover, to continue the resection. And if speech does not recover, I stop the resection. If the patient has difficulty in naming or difficulty in repetition, etc., I usually stop surgery. Does this clarify? Does this answer your question?
Yes, it's actually helpful. It sounds like you can make some individualization, but you have your areas and then you have your parameters during surgery. That helps. Thank you.
Yes, thank you.
All right, anybody have any other questions? All right, thank you, Dr. Comair. We really appreciate you being present. Thank you.